Hi, hello, namaste. Do you know what's the most common prescribed drug in our OPD? Yes, it's the lubricant drop. With so many formulations in the market, did you ever wonder what is the right one or how to choose the right one? Today, let us learn about most common drug prescribed in our OPD, that is the artificial teardrop. Hi, I am Dr. Vijayalakshmi, Associate Professor trained in cornea cataract refractive surgery from LV Prasad Eye Institute. Without a delay, let's dive in. This is an interesting article which I have come across recently, and I think it is a very important summary of the artificial tear substitutes which we use in our daily life. Let's learn about what is dry eye. Dry eye is actually a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film. This definition is very important to know about what lubricant we have to use in the which we are going to learn in the later part of this talk. So it is accompanied by symptoms of tear film instability, hyperosmolarity, and ocular surface inflammation and damage, and also neurosensory abnormalities. Global dye eye market is a very large market, and many people are suffering because of lot of screen uses and all. Let us learn about the natural tear film. As you all know, it is made up of three layers: the lipid layer, which prevents evaporation; the aqueous layer, which provides the bulk oxygen and the nutrients; and mucin layer, which anchors the tear film to the epithelium. So dry eye is basically a system failure and just not one problem. So what are all the problems? There is tear film instability, hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities. This is important to classify all the different type of brands which are available in the market. So there are three building blocks of any artificial tear substitute. First one is the active ingredient, also called as the demulcent. This is an FDA approved polymer that thickens and lubricates the tear film. It is mandatory for regulatory approval, and maximum you can add 3 demulcents per product. Second component is an inactive ingredient, but this is the one which is going to tackle all the different pathologies of the dry eye. So here you have humectants, osmoprotectants, oils, surfactants, electrolytes, antioxidants, and which have protective and modulatory roles. Next comes the preservative. As you all know, every drop needs some amount of microbial safety to prevent contamination in multi-dose bottles. So there are various types which we'll be learning in the next few slides. But once you see these three layered structure is the basis of every sort of lubricant which you are seeing in the market. Now, what are all the active ingredients? As I told you, these active ingredients are called as demulcents, and we can have 3 demulcents in maximum in a tear film. So they can be cellulose derivatives like CMC, HPMC, hydroxymethyl cellulose, and methyl cellulose. What is the main role of it? It is a thickener, it stabilizes the emulsion, and it boosts the viscosity. Next, dextran can be one more demulcent which improves the mechanical strength of the tear film. Next can be a gelatin, which is a gelling agent. The polyols like the polyethylene glycol, polypropylene glycol, which reduce the hyperosmolar damage. Or the polymers like the carbomer, PVA, and povidone, which integrate with the lipid layer. So you have to remember that maximum of 3 demulcents may be combined in one artificial tear supplement for regulatory approval. Now, the inactive part, which are called as biologically active excipients, are of various kinds as we have discussed previously. First one is the osmoprotectants. What are osmoprotectants? They protect the epithelial cells from the hyperosmolar stress and the apoptosis, like trehalose, erythritol, glycerol, betaine, taurine, and L-carnitine. The next group are the oily agents and surfactants. These are castor oil, soybean oil, mineral oils, and polysorbate. So this stabilizes mainly the lipid layer. You have antioxidants which are acting against as free radical scavengers like vitamin E, B6, B12, CoQ10, and lipoic acid. Then you have humectants, which are hygroscopic molecules which prolong the active ingredient efficiency and they mimic the mucin layer. Then you have electrolytes to prevent osmotic imbalance and to preserve the osmotic balance and to give a comfortable pH. Wound healing agents like high molecular weight hyaluronate and cationic emulsions are anti-inflammatory and replenish the epithelium and lipid layer. So each excipient solves one broken mechanism. This one is very important to remember. The hyperosmolar stress on the cells is taken by the osmoprotectants, which are the trehalose, erythritols, betaine and taurine. The poor water retention or the mucin deficiency is taken up by the humectants, which act like a sponge and retain the moisture, and these are the molecules like the hyaluronic acid will act in that. Then you have the evaporation part of it, which is taken up by the oily agents and the surfactants like the castor oil, mineral oil and polysorbate 80. Then you have the osmotic pH imbalance, which is tackled by the electrolytes and buffers like the borate, citrate, sodium, potassium and calcium. Then the cellular damage is tackled by the antioxidants, wound healing agents, vitamin E, CoQ10 and high molecular weight hyaluronate. So every excipient category maps exactly to one broken tear film mechanism. So if you learn this mechanism is very important, and if you learn it, the ingredients don't make you panic. Now, the preservatives, as I told you, these are the trade-off. You need to prevent contamination, but at what cost? Is it to the ocular surface? No. So there are three types of preservatives, which are usually the older ones are the detergent type, which are benzalkonium chloride like polyquad, chlorhexidine gluconate, PHMB, cetrimide and benzyl alcohol. Significant ocular surface toxicity can occur with chronic use. This is very important. You have to remember this. Then you have the newer ones, which are oxidative type, which are puride. These are basically disappearing preservatives which break down to water, oxygen, chloride and contact with the eye. The newer ones are Sofzia, which are basically behave like vanishing preservative and they have low surface impact. Why detergent preservatives are a trade-off? Because the same mechanism that kills the bacteria also damages your patient's epithelium. So the benzalkonium chloride should not be used in a patient to whom you are giving very frequent lubricants. The corneal epithelial cells might be damaged because of that. So if you are instilling someone with a frequency of more than 4 to 6 times per day, it is better to switch to preservative free drops. Now, what are the preservative free drops and when you have to use them? The other two things, which are puride derivative and the Sofzia ones, are usually seen in the preservative free drops, and we have to use them whenever we are using when you are using the formulations for more time. Preservative free formulations should be switched to anyone who is exceeding 4 to 6 times a day, and you have to make sure that whenever you are using, when you have ocular surface disease, epitheliopathy, you have to avoid the detergent preservatives, and in contact lens wearers also preservative free are strongly recommended. Now, if we look at all this and if we reclassify the tear substitutes, which was done by Barbino et al., they have divided the tear substitute as wetting agents, which are basically the viscosity and enhancing demulcents, plus oily agents. They lubricate the ocular surface with limited residence time. Then you have multi-action tear substitutes, which improve the tear film quality and quantity and go beyond the lubrication. And you have ocular surface modulators like osmoprotectants, antioxidants, wound healing agents that actually interact and influence the ocular surface to counteract with the dry eye disease pathology. So as there is an increasing degree of interaction with the ocular surface, as there is more severity of that, you can go towards these drops. So when there is a mild occasional dry eye, you have to use a wetting agent. That simple lubrication is enough. You don't have to overtreat. When there is a moderate dry eye, multiple action tear substitute which has a role in both quality and quantity improvement will be used. Then you have ocular surface disease with corneal staining. Whenever it is there, passive lubrication will not fix, so you need ocular surface modulators. So if you look at in gross all the molecules, if you take out a lubricant bottle and see all the molecules, they will actually have all these three permutations and combination only. So you have to decide based upon what is there in that lubricant drop. So how do you choose it by ingredient? So whenever there is an aqueous tear deficiency, you try to use demulcents. Whenever there is evaporative dry eye, you try to use either humectants or oil emulsions. To tackle the hyperosmolarity, you use osmoprotectants, and epithelial damage with corneal staining, you use both osmoprotectants and hygroscopic agents. Now, based upon the severity, again you can choose. Whenever it's mild, you can go with simple CMC, and then as it becomes moderate, you can go ahead with adding substances like osmoprotectants and all. And when it is severe, you have to tackle the inflammation along with the just giving lubrication to the surface. So the step ladder approach is to start mild disease with one agent and others as required. Nighttime, you have to prefer gels and ointments for prolonged overnight comfort. What are the practical tips you have to learn for the clinic is maybe it's not relevant to use ATS at the bed, artificial tear supplement at the bedtime for evaporative dry eye, and you have to use a gel or ointment for that, and titrate the frequency of instillation based upon the diurnal symptom variation, and avoid high viscosity agents during the working times as it might blur the vision. Know all the components and not just the active ingredient and their functions. With corneal epitheliopathy and staining, choose something which has protective excipients like trehalose, amino acids, hyaluronate, and electrolytes. And avoid unwanted polypharmacy. Use a mesh approach, not everything at once. When artificial tire substitute is not enough, what do? You can go for punctal occlusion, you can go for anti-inflammatory therapy, you can address the lid and systemic disease, and advanced severe cases, maybe you will have to go for other modalities of treatment. So from this lecture, if you really want to remember something, you just have to remember that every artificial tear supplement bottle is an answer to one question: which specific piece of the tear film homeostasis is broken in this patient, and which molecule will correct it. Once you answer this question of your patient, you can easily curate whatever drug you have to give to the patient. Let me end you with something to ponder around. I am giving you three scenarios and you think around and see which molecule you have to use. First, there is a screen worker, a 45-year-old office worker with mild intermittent grittiness, no staining, long screen hours. What kind of agent will you use? Second one is a Jogren's patient, and the third one is an MGD patient. Which type of lubricant will you use for all the three of them? Is it the same, or will you customize it? I'm sure at the end of it of this lecture you should be at least be able to tell that it should be customized. So work about according to the framework and come with an answer. The key takeaways from this lecture, I would say, are that artificial tear substitutes are the mainstay of dry eye disease, and rational selection is very, very important. Not a single class is proven superior to other. So it is very important that you choose the molecule which is apt for that patient and escalate to anti-inflammatory and advanced therapy when artificial tear supplement alone fails. Thank you. I hope you have liked the lecture. We would like to know on what topics you want to hear next. Please feel free to interact in the comments, share this video and subscribe to our channels iMusing if you like our content. Thank you.